Hi, I'm Dr. Ray, and I'm here to talk to you about development of the placenta and the fetal membranes. The placenta has many functions, some of which are listed here. It's going to synthesize some products like glycogen, but also is going to synthesize other things like human chorionic gonadotrophin and also some other hormones. We have a placenta is there to protect the growing embryo and fetus from the immune system of the mother, and also the placenta is going to allow for blood and nutrients to reach the growing embryo and fetus, and for waste products to make it back to the mom's circulation so that they can be excreted. And so the placenta is a very important organ. This is a picture of one here that you're actually looking at the side that was facing the fetus. So I'm going to go back in time with you for those of you who have been on this path of human embryonic development with me. And we talked about the embryo and how it implants into the wall of the uterine cavity, the endometrium. And you can see it makes contact, and then you have this trophoblastic layer that's going to separate into two layers, the syncytiotrophoblasts and the cytotrophoblast. This is further along in development, but you can see the syncytiotrophoblasts, how it invades the uterine lining. And in this place here, you're looking at the blastocyst, and you can see the embryonic disc here, which is just 2 layers. And you can see the developing amnion up here. And then you sort of just see the blastocystic cavity pictured down here, and this is much further along. And so what I want to do is make sure that I step you up to where we're at today, especially since it's been a few weeks since we did this other material. So here where you have the essentially the blastocyst has implanted fully into the uterine wall, which happens about day 7. You can see the syncytiotrophoblasts and the trophoblasts out here. And then you can see the embryonic disc pictured here with the amnion here. And then you can see this singular cavity here, this blastocystic cavity. And I think one of the concepts that is hard is understanding how this cavity becomes the umbilical vesicle, and how you end up with an extra embryonic celoma cavity. And so I want you to pay attention to the yellow highlighted area, which is the extra embryonic mesoderm that's underlying the cytotrophoblast here. And so if we, sorry about that, I'll just step. And the next slide here, you can see that celomic spaces, these little spaces, begin to develop in the extra embryonic mesoderm. And these spaces are going to coalesce, and it's going to form a space in here, which is the extra embryonic coelom. And then it actually causes a separation between this mesoderm, this somatic extra embryonic mesoderm and splanchnic extra embryonic mesoderm, that allows for this to become the umbilical vesicle. So this umbilical vesicle is not fully sort of developed in this situation here, but rather actually gets pinched down, and this little tiny, what they end up calling that, the primary umbilical vesicle, ends up here, and this becomes the definitive umbilical vesicle. It can be also called the secondary umbilical vesicle. So we've been talking about, up until now, we have really been highlighting this area of embryonic development. This is where we start the 3rd week, where we get the primitive streak and the invasion of mesoderm into this disc. And now then we end up with a trilaminar embryo, and the trilaminar embryo folds and incorporates the umbilical vesicle, and then the amnion gets wrapped around. And so we talked about that, and if you haven't seen that, or you want to check out the other video in weeks 3 through 7, please do. But what we're going to do for this session is talk about the rest of the membranes here, these fetal membranes that are out in this vicinity on the outside. So that's why I kind of wanted to take a step back so that you could see where we were starting from. Okay, So the uterus around this implanting embryo isn't really just not seized. It's actually going to have changes that is going to protect itself and also protect the implanting embryo from an immune attack. These changes occur on the cellular level, and they also affect the blood vessels, and it's called the decidual reaction. And so this is a uterine change to an implanting embryo. And so what's depicted in these pictures are uterine glands. These are depicted as uterine glands in the endometrium. And that's why they draw these cells all linked together, because it's an epithelium of a gland. And then what they're also depicting here are uterine arteries. And so you can see these arteries that are in this illustration. And so what happens is, as the syncytial trophoblast invades the uterine lining, it opens up these glands, breaks them open, and also ruptures through some of the arteries, and it makes this really rich fluid to give nutrition to the developing embryo. And so it's sort of everything sort of runs together, and you get also some enlargement of these cells in the glands. They get large. I actually have a picture of them here, and they secrete a lot of glycogen, and they accumulate a lot of lipids, and that's why the cells look so big and full. And so these are decidual cells, and that is the uterus trying to give nutrients to the developing embryo. All right, and so now I'm going to focus your attention on the trophoblasts that separated out into two layers. So the outermost layer that was invading, that kind of didn't really look like it had a lot of organization, is the syncytial trophoblast, and that's depicted here in white. This is sort of a cross-section through the wall, a closer up view of this here. And then underlining cytotrophoblasts, which do look like individual cells are connected to each other. And then under that, there was a layer of mesoderm, of extraembryonic mesoderm, and the one that lines this cavity here is called the somatic, but that's not really something you have to worry about, but it just is, so I thought I would throw that in there, that there is the little bit of mesoderm that's around the umbilical vesicle is called the splanchnic, extraembryonic splanchnic mesoderm. All right, so all of this together, all of these three layers together is referred to as the chorion. So when someone asks you or refers to the chorion, they're talking about this whole layer here, the mesoderm included, with the cytotrophoblasts and the syncytial trophoblast. Okay, and then really early on, these protrusions made up of the chorion is going to pretty much envelop all around the wall of the chorion. So you're going to get these villi that are going to protrude out. And I kind of talked about early cardiovascular development the other day, and I showed you how these blood islands accumulate all over the walls of the umbilical vesicle, and it's also forming out here in the chorion with these villi that are starting to protrude out. These are vascular processes, so they're going to make blood vessels. Okay. And so they're referred to as primary chorionic villi early on, when you just have, this is a cross-section of a villus, where you just have the syncytial trophoblast that is surrounding a cytotrophoblastic core, and that's what it would look like in cross-section. So this is the big picture, this is closer up, and this is the closest up in cross-section. And that's a primary chorionic villi. A little farther along in development, we refer to the next villus as a secondary chorionic villus when that villi gets infiltrated by mesenchyme. So as mesenchyme kind of comes into the core, we call that a secondary chorionic villus. And then as capillaries grow inside the mesenchyme, we refer to that as a tertiary chorionic villus, and that's the end of the development of these villi. So these villi are going to develop into the placenta, or the fetal part of the placenta, and so they're very important for establishing circulation with the mother. All right, so that brings me to the next big picture item, and maybe I should have put this on the other side. This is the fetus over here, and so the villi are going to protrude all over that chorion, and this is much further in development. This is what they're going to turn into. So these are like a whole bunch of tertiary villi much farther back. They actually have bigger structures, their stem and branch villi as well. So that's going to make up the fetal part of the placenta, so that came from the chorion, the fetal part did. But then the mom, actually, the uterus, actually does contribute to the placenta. They're a smaller portion, and that's considered the maternal part. And so that is going to make up of the part of the endometrium that was adjacent to the part of the implantation site. And so it's going to respond and react to the syncytial trophoblasts, and this part of the uterus is going to have arteries that are going to open up into a space and pretty much let blood go into the space. And then essentially the space is going to be drained by uterine veins, and it's going to return to the mom's circulatory system. So that's how the circulation works. And so what happens is that these little tiny capillaries that form in these tertiary villi, they are going to expand and branch with each other into larger and larger arteriocapillary networks. And that's what you're looking at here. You're looking at a histologic section of a placenta, and you can see these are villi, and that would be tertiary villi. What happens is that the actually syncytial trophoblast gets very attenuated. You really can't even see large sections of the cytotrophoblast, and here you can see capillaries with blood cells in them, and this is some connective tissue. And this space here, all of this white space, would be the space, the intravillus space, where blood would normally be bathing from the mom, would be emptying into here and bathing all of these villi to allow for exchange to go across the barrier. Okay, so those are a couple new terms. As you get these arteriovenous branches that form and get bigger and bigger, you end up having larger and larger villi. So the largest villi are these ones depicted here. They're called stem villi, and they are going to connect to the plate that the embryo and fetus make. That's called the chorionic plate. And off of the stem villi are lots of little tiny projections called branch villi, and those are the ones where most of the exchange is going to actually take place. And then the white here, the white space here that are between the branch villi is called the intravillus space, and that's where blood from the spiral arteries from the uterus are going to empty blood, pretty much allow it to bathe all of these little branch villi with blood. Whoops. And then the veins will drain the space. So there's no mixing of blood. The blood doesn't come into arteries and veins and go to the fetus, but rather substrates are going to cross the barrier and exchange between mom's blood in the intravillus space and the blood that goes to the fetus that are in the vessels in these branch and stem villi, and up here, these larger ones that are in the chorionic plate. Okay. Now, another topic I want to bring up is an interesting structure that's called the Saitotrophoblastic shell. And the Saitotrophoblastic shell is unique because it is really the anchor that holds the placenta, the fetal part of the placenta, to the decidua basalis of the uterus. And so this is the barrier that the spiral arteries and the veins have to go through and basically empty the blood into the space. So without the cytotrophoblastic shell, that is the outer sort of barrier, there wouldn't be a space for the blood to fill. And so it's kind of a little bit of a concept, because even looking at histologic slides, the cytotrophoblastic shell is broken off, and so it's just something that you, looking at the drawings might help, but it is going to essentially be the closest part to the uterus of the fetal membrane, of the fetal placenta, part of the placenta. Okay, and so I think I might have skipped a slide. Nope. All right. And so on this slide, you can see the larger stem villus, which you can see several vessels in the stem villus, and then you can see a little branch villus branching off of the stem villus. So I just wanted to show you that this was real, and the space out here with all of this protein aggregate here, this is the intravillus space where mom's blood would normally be bathing the walls, and so across this, this is the membrane across here that where substrates have to pass. So grossly, when you're looking at the placenta, this is what the mom's side of the placenta looks like, so the side that's adjacent to the uterus. There are septa, placental septa, that are made up by parts of the decidua basalis, and these septa make the villus that are coming from the chorion, from the fetus, branch into these irregular septations called cotyledons. So here you can see a whole bunch of cotyledons. They're septated. They have breaks in between them. I just highlighted one for you. And so one of these would have 2 or 3 stem villi, and then they would have lots and lots and lots of branch villi that were projecting off of them. And then after the placenta comes off, there might be a few pieces of the underlying uterus called the decidua basalis that might be on there, but it would be very thin. Okay, and so essentially, I also wanted to remind you that the amnion is a major player. So the creation of the placenta, of actual making the vascular processes that are going to exchange substrates with mom's blood, those come from the chorion and those primary, secondary, tertiary, eventually tertiary villi. But the amnion does become a player because if you remember, the flat embryonic disc folds, and when the embryo folds, it brings the amnion from the dorsal side to the edges to the ventral side, so it's connected to the umbilical stalk. So essentially, the amnion ends up being all the way around the developing embryo and eventually fetus. And it just gets bigger and bigger. So as this amniotic sac gets bigger and fills with more and more fluid, it is going to come up and abut adjacent to the chorionic sac. And so we end up having an amniochorionic membrane, not just a chorionic membrane and not just the amniotic membrane, but they are actually fused together. Occasionally they can separate, but they're supposed to be fused together. All right, and I mentioned it a couple times, and I want to explain to you that there are a few different regions of the decidua of the endometrium of a uterus that has an implanted embryo. And these are clinically important because you might need to describe where something is in relation to the developing embryo. So you need to know these terms. The decidua basalis is the part of the endometrium that is deep to where the implantation site is. So if here's the developing embryo and fetus, the conceptus, this is a decidua basalis. And that's going to be the area where the chorion on the fetal side is going to continue to grow into the placenta. Now, the decidua capsularis is the part of the endometrium that was on top of or overlying or more superficial to the implanted blastocyst. So if you remember when the back here, when the implantation occurred, this is the embryo growing here. See how the uterus sort of capped off, like it implanted and then it resumed its continuity. So this area here would be considered the decidua capsularis, and this area here would be considered the decidua basalis. And then the decidua parietalis is essentially just the rest of the endometrium that is not either one of those two things, okay? And this is a ultrasound here of, you can see the, I'm not really sure what we're looking at, but here, this would be the area of the placenta. I mean, I just see space with fluid. But this, it pointed out, is where the decidua parietalis would be up here, and this was where the capsularis would be, and this is where the basalis would be. So just to give you sort of an understanding of where you could use this information to talk to other clinicians. Okay, so at the beginning, the chorion has villi that are projecting all over, all around its surface. But the fetus actually enlarges so that the amnion is going to come up and contact the chorion, but even before that, the chorion is also going to come in contact with the decidua capsularis. And that is going to actually cause blood flow to be reduced in that part of the chorion and those villi to degenerate. And so it actually makes the rest of the chorion here that is not going to be overlying the decidua bassalis to become smooth. So we call this the smooth chorion. So that's why the rest of the membranes don't have villi projecting all over it. Although in some very rare circumstances, they can continue to have villi. When I was doing a little bit of research, I saw that it was actually possible. It's just not typical. All right, so what is the placental membrane? So the fetal membranes are the chorion and the amnion. So we talked about what those membranes are. But if someone asks you what the placental membrane is, that's the barrier that is between the maternal circulation and the fetal circulation. So if you think about the tertiary villi and what makes up the wall of the tertiary villi, then you could put together, or hopefully begin to picture in your mind that you're going to have syncytiotrophoblasts that's going to be on the outer aspect of this villi. So blood is going to have to, or substrates are going to have to, not blood, cross the syncytiotrophoblasts. It will have to cross the saitotrophoblasts, a little bit of connective tissue, and the endothelial wall of the capillary, the fetal capillary that's going to go to the fetus. So that's what substrates have to cross back and forth to be able to have exchange between the mom and the fetus. Now, it's also noted that as the fetus continues to grow, this barrier thins out markedly, and the cytotrophoblast becomes very attenuated and kind of almost non-existent. So you see more of the syncytiotrophoblasts, but you don't see as much of the cytotrophoblasts later on in pregnancy. Okay, and so just terms, the chorionic plate is the part of the placenta that came from the fetal parts, fetal membranes here. And the basal plate is the term that's referred to the part of the placenta that came from the uterus, or the decidua bassalis. And this is what it looks like. So if you just had a baby, or have a patient that has a baby, and you look at the placenta, this is what the fetal side looks like. It's nice and smooth because it's covered with the amnion. You can see the vessels in the chorionic plate, arteries and veins, and they are going to converge here at the umbilical cord, which is going to go to the umbilical region of the fetus. If you turned it over, you would see the maternal side that has all of the cotyledons, and it's much more irregularly shaped, and it's not as smooth because you have lots of branch villi that are projecting, and you have arteries and veins from the uterus that's going the opposite direction. So it's very irregular and more rough shaped. This is what the chorionic plate looks like in histologic section. You can see the little villi that I was showing you earlier. This is a much lower magnification. And here you can see how large the chorionic plate is and how large the blood vessels are inside. It's just a little accent there. Okay, we are several different transport mechanisms that allow substrates to cross this placental membrane. This is you're just sort of getting started with understanding transport mechanisms, or some of you might already be experts, but just to refresh your memory or to start you off, you can have simple diffusion of substrates, and so basically things can go back and forth freely, like oxygen, carbon dioxide, carbon monoxide, and also water goes across freely. You could have facilitated diffusion, where you actually use a carrier or an electrical gradient to have something go across this membrane. You can have active transport, where you need ATP in order to cross the membrane, and lots of ions and molecules are going to fall into that category. And also there is a cellular transport mechanism called pinocytosis, where you can essentially have this constitutive rate of engulfing substances that are on one side and then crossing the membrane to the other side. So that is sort of more of a unique circumstance, although it happens a lot in cells, especially with just extracellular fluid, like water. Okay. And so this is sort of to give you just a little more detailed information. You're going to learn a lot of this in different classes that you're going to take. But just to give you the heads up that there are a lot of nutritional substances that have to cross this placental membrane. Like you need cholesterol, definitely water and glucose, like I've mentioned before, but other things like amino acids and vitamins, phospholipids. So protein-based hormones do not actually go across the placental membrane in large amounts, except for thyroid hormones. There are other hormones that do, testosterone and synthetic prostans do cross easily. Let's see, other things. Oh, maternal antibodies and proteins, so you get a little bit of immunity that is going to come from the mom, because the fetus really doesn't have an active or working immune system at birth, but there is some immunity that is actually handed over from mom to the fetus, luckily. And your textbook has a couple paragraphs and it talks about the different things that that are actually offered and as protection, and some things that are not, that are important. So you might want to read those clinical boxes. And then very importantly, waste products like urea and conjugated bilirubin are crossing the placental membrane very easily. And if you're interested in more in-depth information, there was a cool paper online that I found about more detail on the placental structure, its function, and also how drugs cross it and can be a problem. Because generally, most drugs, if not all, but most drugs that you give a pregnant woman are going to cross the placental membrane. And so they can cause major birth defects, they can cause minor problems, or it can really be unknown. And so it is something that you're going to have to definitely be aware of and kind of keep up with the recent developments in this field, especially if you're caring for pregnant patients. Okay, the umbilical cord itself, I know we've talked maybe a little bit about it. You haven't really had a chance to think about it maybe as a standalone structure. This is a picture of a baby, a newborn that was born in the caul, so has been born within its fetal membranes. The amniochorionic sac is still attached. And then here you can see through it the umbilical cord. And so it is going to originate from the connecting stalk, and it is going to allow blood to move, well, basically substrates to move from the baby to the mom, and blood is going to move back and forth and exchange these substrates relatively freely. And the umbilical cord allows the embryo and fetus to move around and do flips and essentially not be confined to one small area, because the baby comes in all different shapes and sizes, and the cord can be of different lengths. Oftentimes the cord is wrapped around the baby's neck loosely, and this is pretty common. In 20% of the cases, I've seen it several times. And it's not any no complications arise from that. But you can very occasionally have a true knot in the umbilical cord, which could compress the vessels within the umbilical cord and decrease the blood supply. But that's very very rare, actually. A lot of false knots, because the umbilical cord, the vessels are longer than the cord. They make this sort of twirling pattern around the umbilical cord itself. So when you're looking at a section of the umbilical cord, there's going to be one large vein, and that's going to be the oxygenated blood that's coming from the placenta to the fetus. Okay, that's the direction of the blood flow. And I've highlighted it here with the green arrow, and that's the one that's going to go up towards the liver. So the umbilical vein is going to come in through the umbilical cord and go up towards the liver through that falciform ligament that you all are looking at in lab. And then there are two umbilical arteries, and the umbilical arteries are going to come alongside the bladder, which will eventually be the urachus. And that's where you get the medial umbilical folds from. And I think you're actually looking at those right now in lab too. And so those are depicted here in this section. So that's what usually is contained in the umbilical cord as far as vessels are concerned. Although there can be variations. If there are variations in the number of umbilical arteries, then sometimes that's a signal of other birth defects as well. So, Okay, the disorder of preeclampsia, we're going to talk about this in our flipped classroom session, but it is a very serious disorder that just briefly, it involves several different things. They don't really know 100% why someone develops preeclampsia, but they do know that it comes along with maternal hypertension, so the woman has very high blood pressure. She has proteinuria, she has abnormal quantities of protein in her urine, and then a lot of edema. So when you're pregnant, you have a lot of extra fluid, so you can feel sort of swollen, but this is marked swollen, like a lot more than how you felt sort of just being pregnant every day, and it can come on very suddenly. And so it can lead to convulsions that can result in a miscarriage, and it can also result in placental infarcts, and anything that lowers blood supply to the baby is going to pretty much be a large problem and a sign for concern. It can cause the fetus to miscarry. And so this is a serious condition, and we're going to talk about more of this. I have this link in here if you want to watch this woman's YouTube video, and she talks about her condition and how it affected her. And then another condition is called gestational choriocarcinoma. And so this is a abnormal proliferation of the trophoblast that can result in several different types of malignant tumors. And I know we talked about this a couple times in class already, but this woman tells her story, and I really liked her movie. So if you get a chance and you want to really understand this condition further, you can watch her talk about her condition. And the thing about these types of tumors is that they're really sensitive to chemotherapy, so they're really curable if you can detect it early. So it is something you want to look out for and keep as a differential diagnosis. Okay, some common placental abnormalities. The placenta can vary in shape and size like quite a bit, and generally there's usually not a lot of clinical consequences of this. However, there are a few cases where that's not true. So placenta accreta, that's where you have abnormal adherence of the chorionic villi to the myometrium. So it's supposed to be just on the endometrium, but it can go through and adhere to the myometrium, and you can have trouble with separation after birth. The placenta is supposed to separate from the endometrium with maybe a little bit of the endometrium attached. Placenta percreta is where you have the chorionic villi that penetrates the full thickness of the myocardium. So that's here, depicted here, where you have a lot deeper of an implantation of the chorion into the decidua basalis all the way through the endometrium and through the full thickness of the myometrium. And so you could see how this is going to be problematic, because you may have to remove the uterus. Unfortunately, it's not always that case, but you can sometimes have just abnormal adherence of the placenta, in which you can sort of maybe remove without losing too much of the myometrium. But it is possible that you may have to remove large amounts of the uterus, or even the uterus, if you cannot remove the placenta in any other way. And then the other abnormality is called placenta previa, and that's where the placenta implants really close to or over the internal os of the uterus. And so the baby can't come out of the uterus without rupturing the placenta. So that would be of dire risk to the baby and the mom. Okay, so after the baby is born, I just want to give you kind of a heads up of what happens, just for your continuity of knowledge here. Because the placenta comes off the wall of the uterus, you still have the spiral arteries that are releasing blood into the space, but the space is gone. And so the woman bleeds for several weeks after birth. And those spiral arteries will clamp down faster if the woman is breastfeeding or able to stimulate uterine contractions to help clamp down the uterus and keep those arteries constricted. And the uterus doesn't just immediately return to its original size. It's still enlarged and it's stretched, and it'll take several weeks for the uterus to return back down to its non-pregnant state. And then, like I mentioned, breastfeeding does cause regular uterine contractions, and that helps stimulate uterine constriction and help keep those spiral arteries constricted to decrease bleeding. This is what the placenta looks like right after delivery. Here you can see the fetal membranes that are made up of the chorion and the amnion, or the amniochorionic sac. Here's the umbilical cord, and this is the chorionic plate, the fetal side of the placenta. You might be wondering what the importance of amniotic fluid is. Here you have another baby here in the caul that's within the amniochorionic sac. But the fluid is going to allow the embryo and fetus to sort of float in this position that allows it to move all around, and it allows for a proper limb development and proper craniofacial development because they don't not applying a lot of pressure to any one body part. And so it's really important for development for the embryo and fetus to have full range of motion and not have any constriction on its body during development. It also is a barrier to infection. So the uterus is, although you have a cervical plug, it's still open through the cervix. And so the fluid is going to prevent any kind of microbes from coming up and attacking the placentas. So that is an important part of amniotic fluid. It is also really important for lung development. The baby is supposed to be able to breathe in the respiratory system, breathe in the amniotic fluid, and also swallow the amniotic fluid. And it will even urinate the amniotic fluid out into the fluid to be able to make sure that those systems develop normally. And so that it is an important thing that has to occur, and if it doesn't, then it's either a sign that those systems haven't developed properly, like for example, the respiratory system, or you might have some esophageal atresia. And so that's something that you would want to look into further if for some reason there's too much amniotic fluid, which we'll talk about in a second. And so first is going to cushion the baby by giving a little bit of extra padding, like having a globe with a bunch of fluid inside. Has maintained body temperature, and let's see, that's pretty much the good stuff there. So what about disorder of amniotic fluid? Well, there's basically two terms, and one that means too little, which is oligohydramnios. It means you have too little amniotic fluid, and most common reason for oligohydramnios is a premature rupture of the amniochorionic membranes. So that is the most common reason. You can also have renal agenesis. So essentially, if you don't have kidneys that developed properly, then the fetus cannot urinate into the amniotic sac and have enough amniotic fluid. So that's sort of a sign, and not necessarily a cause. And then polyhydramnios is where you have too much amniotic fluid, and most of the time, nobody knows the reason. So it's idiopathic. It could be a sign of severe defects of the central nervous system or esophageal atresia, like I mentioned. If the baby isn't able to swallow amniotic fluid, then it's more of a sign that there might be a problem, not necessarily a cause. And so this is a case of oligohydramnios, and so there's too little amniotic fluid here. Here you can see that the fetus's head and the fetus's torso. And so this could put undue pressure on the fetus, so the baby's not allowed to move around enough, and it might affect limb development or affect development of whatever part of the body, the facial or whatever the part of the body is getting too much pressure. And then there's another syndrome called amniotic band syndrome, and that is when you have irregular sloughing of maybe bands of amnion, so they can kind of come out from the regular amniotic membrane, and they come off and wrap around parts of the baby. And in this instance, it's just around the finger, and it constricts the blood flow to the part of the body that the band of amnion is wrapped around. And so it could be just a finger, but it could also be the face or the head. And so definitely it's going to be an individual case on how much risk this poses to the developing fetus. All right, so since we've increased our fertilization therapies, we have a lot more multiple pregnancies than usual, normal or typical before we had fertilization therapies. And unfortunately, with these types of of increased multiple pregnancies, we have increased risks. And one of the risks is having a fused placentas between two babies that are being carried at the same time. And so you can have anastomosis between blood vessels where you have fused placentas. And so one of the things that can happen is that you get erythrocyte mosaicism. And so you might have, the babies may have two different types of red blood cells, okay? That's kind of interesting and can be problematic, but one thing that is definitely problematic is called twin transfusion syndrome, where you have these types of arteriovenous anastomosis between twins. And so where a baby should have gotten more blood, it's been shunted over to this baby here. And so what happens is that the one who is missing out on its blood supply and it's being literally given away to the other baby, this baby ends up being small and pale and anemic. And then this baby over here who's really getting too much blood, too many blood cells, end up having too many blood cells and can have congestive heart failure. So you can treat this if you catch this early, but it can also have serious implications. Okay, so that's all the basic information that you need from me to be able to do the active learning session. I hope that I helped make it a little bit clearer for you. I know that the development of these fetal membranes and the placenta is a little abstract, but you might want to watch the beginning part again just to make sure that you can go step by step, and I'll hit you up with a bunch of questions into the class session. Thank you for your attention.